Summary of celiac disease. Definition: celiac disease, an autoimmune disorder triggered by gluten in genetically predisposed individuals, leading to damage in the small intestine. Epidemiology: gender prevalence, more common in females than males. Age of onset: can occur at any age, often diagnosed in childhood or early adulthood. Geographical prevalence: higher in individuals of Northern European descent. Etiology: genetic factors, strong association with HLA-DQ2 and HLA-DQ8 alleles. Environmental trigger: gluten ingestion from wheat, barley, and rye. Hashtag pathophysiology: gluten consumption leads to an autoimmune reaction in the small intestine, causing damage to the villi, villus atrophy, and resulting in malabsorption. Clinical features: gastrointestinal symptoms, diarrhea, bloating, abdominal pain. Extraintestinal manifestations: anemia, osteoporosis, dermatitis herpetiformis, and neuropathy. In children, failure to thrive, delayed puberty, and growth retardation. Diagnostic serological tests: IgA tissue transglutaminase antibody, TTG-IgA, as the initial test. Additional tests include IgA and IgG deamidated gliadin peptides and anti-endomysial antibodies. Confirmatory test: endoscopic biopsy of the small intestine showing villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis. Histopathology: classified by Marsh stage, ranging from lymphocytic infiltration to complete villus atrophy. Differential diagnoses: tropical sprue, similar gastrointestinal symptoms but occurs after travel to tropical regions and responds to antibiotics. Whipple disease, caused by Tropharema whipli, characterized by malabsorption, arthritis, and systemic symptoms. Treatment: mainstay, lifelong strict gluten-free diet, avoiding all products containing wheat, barley, rye, and derivatives. Nutritional support: address deficiencies, e.g. iron, calcium, vitamin D. Complications: nutritional deficiencies due to malabsorption. Associated autoimmune disorders: thyroiditis, type 1 diabetes. Increased risk of malignancies, especially enteropathy-associated T-cell lymphoma and small intestinal adenocarcinoma. Prognosis: with adherence to a gluten-free diet, most patients experience significant improvement in symptoms and intestinal healing, reducing the risk of long-term complications. Clinical case: celiac disease. Patient information: age 28 years, gender female, presenting complaint: chronic diarrhea, abdominal bloating, and unexplained weight loss over the last 6 months. History of present illness: the patient reports experiencing frequent bouts of diarrhea with 4 to 5 loose stools per day. She also notes significant bloating and abdominal discomfort after meals, particularly after consuming bread and pasta. The symptoms have led to a weight loss of approximately 8 kilograms, 17.6 pounds over the past 6 months. She also complains of fatigue and occasional mouth ulcers. Medical history: no previous significant medical history. Non-smoker, occasional alcohol, no known drug allergies. Family history: the patient's mother has hypothyroidism, no known family history of gastrointestinal diseases. Physical examination: general appearance, appears mildly underweight and fatigued. Vital signs: BP 110, 70 mm Hg, HR 78 BPM, temp 36.8 degrees, 98.2 degrees Fair, RR 1600 min. Mild abdominal distension with diffuse tenderness, no rebound or guarding, no hepatosplenomegaly noted. Skin: no dermatitis herpetiformis noted. Hensch laboratory findings: complete blood count CBC, mild microcytic anemia. Serological tests: positive IgA tissue transglutaminase antibody, TTGA. Nutritional panel: low serum iron and vitamin D levels. Imaging and procedures: upper endoscopy with biopsy. Biopsy of the proximal small intestine reveals villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes. Diagnosis: based on the clinical presentation, serology, and biopsy findings, a diagnosis of celiac disease is confirmed. Management plan: dietary, referral to a dietitian specializing in gluten-free diets. Patient advised to adhere strictly to a gluten-free diet, avoiding all products containing wheat, barley, and rye. 2. Nutritional support: supplementation with iron and vitamin D. 3. Follow-up: scheduled follow-up appointments to monitor symptom resolution, nutritional status, and adherence to the gluten-free diet. Repeat serology in 6 months to assess response. Discussion points. Gluten-free diet impact. Discuss the challenges and strategies for maintaining a strict gluten-free diet, including reading food labels and avoiding cross-contamination. Associated conditions. Consider screening for other autoimmune disorders given the association with celiac disease. Family screening. Discuss the recommendation for first-degree relatives to be screened for celiac disease due to the genetic component of the condition. Summary of hypertrophic pyloric stenosis. Definition: hypertrophic pyloric stenosis, HPS, a condition in infants characterized by hypertrophy and hyperplasia of the pyloric sphincter, leading to gastric outlet obstruction. Epidemiology: incidence 0.55 per 1,000 live births. Gender prevalence: more common in males than females. Age of onset: symptoms typically develop between 3 and 5 weeks of age. Risk factors: more frequent in firstborn children, exposure to macrolide antibiotics in infancy, and environmental factors like smoking during pregnancy. Etiology: the exact cause is unknown, but involves a combination of genetic predisposition and environmental triggers. Clinical features: primary symptom, progressive, projectile, non-bilious vomiting after feeding. Physical exam findings: palpable olive-shaped mass in the epigastrium, visible peristalsis. Associated symptoms: irritability, hunger, dehydration, and weight loss. Diagnostics: ultrasound, first-line imaging showing elongated and thickened pylorus. Lab tests: previously common to find hypokalemic, hypochloremic metabolic alkalosis, less common now due to earlier diagnosis. Differential diagnosis includes midgut volvulus, gastroesophageal reflux, and others. Treatment: initial management, rehydration, and correction of electrolyte imbalances. Definitive treatment: Ramstedt pyloromyotomy, a surgical procedure that involves longitudinal splitting of the pyloric muscle without entering the mucosa. Prognosis: excellent with surgical treatment. Full recovery expected with minimal risk of complications post-surgery. Clinical case: hypertrophic pyloric stenosis. Patient information: age 6 weeks, gender male. Presenting complaint: the parents report that their infant has been vomiting after feeds for the past 2 weeks. The vomiting has progressively worsened and is now projectile. History of present illness: initially, the infant would vomit once a day, but over the past week, the vomiting has become more frequent and forceful, occurring after every feed. The vomitus contains milk only, with no bile. The infant seems hungry and eager to feed again after vomiting. Notable weight loss and decreased wet diapers over the past few days. Medical and family history: born full term via normal vaginal delivery, no complications during pregnancy or delivery. The infant has been exclusively breastfed. No significant family history of gastrointestinal diseases. Physical examination: general appearance: the infant appears alert but dehydrated. Vital signs: normal for age, but with signs of mild dehydration, slightly sunken fontanelle, decreased skin turgor. Abdominal exam: visible peristaltic waves moving from left to right across the abdomen. A palpable olive-sized mass in the right upper quadrant of the abdomen. Laboratory findings: electrolytes, mild hypokalemia and hypochloremia. Blood gas, mild metabolic alkalosis. Imaging: abdominal ultrasound reveals elongated and thickened pylorus, confirming the diagnosis of hypertrophic pyloric stenosis. Diagnosis: based on the clinical presentation, physical examination findings, and ultrasound results, the infant is diagnosed with hypertrophic pyloric stenosis. Management Plan 1: preoperative, admission to the pediatric surgery unit for monitoring, intravenous rehydration to correct dehydration and electrolyte imbalances. No oral feeds until surgery. 2. Surgical. Once the infant is rehydrated and electrolytes are normalized, he undergoes Ramstedt pyloromyotomy under general anesthesia. 3. Postoperative. Gradual reintroduction of feeds, starting with small, frequent amounts of oral electrolyte solutions, progressing to milk. Monitoring for complications such as infection or wound dehiscence. Discussion points. Parental education. Discuss the nature of the condition, the rationale for surgery, and post-operative care, including signs of potential complications. Feeding post-surgery. Strategy for reintroducing feeds and signs of intolerance that parents should watch for. Follow-up. Schedule post-operative checkups to ensure proper healing and adequate weight gain.